I think KRAS in general has been one of our most immunotherapy responsive subgroups. So if you kind of take all of the genomically defined subpopulations and then you look across studies, KRAS and sometimes P53, and of course KRAS and P53 are often co-mutated, emerge as the patients who often do the best. So if there's ever a group where there's a little bit of tension between who are we giving our targeted therapy and who are we giving IO, it would be the KRAS, because I do think every KRAS mutant patient should at some point get an IO exposure. That being said, they're not a monolith, so we talked about the STK11 and KEAP1. Within the KRAS submutants themselves, there are different clinical phenotypes that associate with them. So KRAS G12D is more common in never smokers compared to G12C and some of the others. And not surprisingly, we see probably somewhat worse immunotherapy outcomes in those patients compared to that. Now, whether that's the mutation type or that kind of clinical demographic that's driving it is harder to say. But there are some nuances. I'd love to be able to tease that out more, but then we're starting to get subsets of subsets, and so I think we do need to kind of keep building these multi-institutional data sets to look at that. And there is some nice work in that space, at least looking at the KRAS G12D that was led by Jia Luo at the Dana-Farber a couple of years ago, and that's a very helpful analysis as well.